Thank you, Monica, and the organizers for inviting me. It's truly an honor and privilege to be part of this amazing, well-conceived, well-organized conference. And thank you for holding it in Cleveland. And my task is relatively made easier following Mary's talk. It's going to have some little bit of overlap because memory is going to be part of the integral part of the cognition. But the intellectual, okay, let's see here. Does it work? Advance the slide, please. Can we have this changed or something else? Okay, in the next 10-12 minutes, my plan is to talk about a cognitive outcome after the two common epilepsy surgeries in children, hemispherectomy and temporal lobectomy. And I would like to ponder on why this happens, why there is cognitive changes, why some children improve, why some decline, why there is no change. And lastly, limitation challenges of studying cognitive outcome in children. Next slide, please. I understand that everybody here understand what is hemispherectomy. You know, there are two broad categories of hemispherectomy. One is anatomic hemispherectomy, where you remove the whole hemisphere anatomically. And the second one is called a disconnective hemispherectomy. I do not like the term functional hemispherectomy because it doesn't leave any function there. It's kind of a misleading term for many families. They would prefer a functional hemispherectomy. But the reason why we preserve tissue is not to preserve function. It is to avoid acute as well as delayed complications. Advance the slide, please. So irrespective of the type of procedure, the impact on the function is the same. So there is at least a homogeneous population in terms of hemispherectomy surgery. Functional outcome is going to be fairly predictable. Advance the slide, please. So if you look at the neuropsychological outcomes, of course, young children, you cannot do memory. Many children who are very disabled, you are not able to do pre and post-op memories. But there is at least several studies which has done pre and post-operative developmental assessment and intellectual assessment. Advance slide, please. So if you look at the pooled data from 11 different studies with patient numbers ranging from anywhere from 15 to in the 70s, I think most of the higher volume patients are from the Canadian group. 61% are unchanged. Advance, please. And if you and about 29% improvement as defined by an improvement of 15 IQ points. Advance, please. And about 10% declined. This is kind of a recurring theme in general about epilepsy surgery and outcome, especially the cognitive outcome. So what predicts the outcome? So there are several factors that predict the outcome. Advance the slide, please. So the common ones are if the children are significantly challenged before surgery, they have low scores before surgery, the need for early surgery. You know, we often say early intervention is better outcome. But the very fact that some children need very early surgery itself says that their disease is very severe, and their post-operative outcome is not as good. And children with Rasmussen encephalitis, where especially when they have already gained skills, learned skills, and subsequently you have an acquired disease that kind of affects that hemisphere, more so in left hemispheric Rasmussen encephalitis. Previous slide, please. Please. I know you're trying to outsmart my thinking. Previous slide, please. I'm not done with that slide. Okay. So the prognosis is going to be better if the opposite hemisphere is healthy. Of course, the compensation would be better. And if the patients are seizure-free, the developmental outcome is better. The fact that the children are seizure-free after hemispherectomy is a surrogate marker that the opposite hemisphere is healthy. Arrows on the sides. Okay, thank you. And in a study of 43 children, none of the children with bilateral abnormalities had an improvement in the outcome, whereas 38% without contralateral abnormality, especially if they are seizure-free, and they have improved scores after surgery. And we had a similar observation when we did a family survey of 115 families who had hemispherectomy. So we asked the families to fill out a questionnaire, and when we found that, when we analyzed the data, we found that patients with bilateral MR abnormalities and severe preoperative deficits, they have a worse language outcome. And children who had a younger age at seizure onset, especially in infancy, they have a worse reading outcome. And whenever children have seizure recurrence, all the functional outcomes are impaired. So if you look at the challenges of hemispherectomy studies, we often think about right hemispherectomy, left hemispherectomy. In general, when we go into hemispherectomy in any child, we usually operate on a non-dominant hemisphere. It's kind of practically a right hemispherectomy in most of the children. Very occasionally, you have an acquired pathology where you end up operating on a dominant hemisphere. Because many times, even though the epilepsy may be refractory, the risk of language decline can be unacceptable to undergo hemispherectomy. And if you look at the 5 common causes of that lead to hemispheric epilepsy, 4 of them occur in early period. Only 1 of them occur as an acquired pathology like the Rasmussen. So if a child has a left hemispheric stroke with seizures at 10 months of age, is very different from a left hemispheric Rasmussen encephalitis with a seizure onset at 5 or 6 years of age. And it is not easy to capture all these complexities in large studies. And the abnormalities on the healthier side is poorly documented in many studies. And of course, what is the impact of therapy after the surgery? And there is a lot of variability in therapies. Even people with best outcomes, they drop out of therapies because of not perceived immediate improvement. So moving on to temporal lobe, and of course, Mary highlighted many of the issues related to temporal lobe. There is a lot of fuss about temporal lobe because we know a little bit more about temporal lobe. As you know, the verbal memory is subserved by the dominant left temporal region, and the non-verbal memory is in the non-dominant side, which means for right-handed individuals, left side is the dominant in most individuals. And also we have reliable testing in patients, especially patients who are verbal as well as in older patients. And temporal lobectomy is probably the commonest surgery done in many of the centers. So that's one of the reasons why we have a lot more data available on this. Okay, let's see if it's going to work here. It's creating some trouble again here. Okay. So when we look at the intellectual outcome after a temporal lobectomy in pediatric, data from 7 studies who have preoperative as well as a postoperative outcome. Postoperative developmental assessment, they have at least 20 patients in each study, and I think the maximum around 50 or 52 patients in study. 75% are unchanged, and let's see here. 9 to 14% are improved, and another 10 to 15% have. Is this going to be a little difficult? I probably shouldn't have done too much of animations here. Huh? 10 to 14% had declined. These scores are similar you see in hemispherectomy. So there is a delay, a lag, something is happening here. Advance the slide, please. So there are very few studies with a comparison group, and whenever there is a comparison group, there is an observation that an increase in IQ is noted only in the surgical group, especially if they are seizure free. And as Mary highlighted in one study, there is an improvement of memory functions on the healthier side. So if you operate on the right side, the left temporal functions will be improved because the left temporal is be released from the constant bombardment by the epilepsy. And the size of the resection definitely impacts the outcome because temporal lobe is a huge structure. As you know, you have the hippocampus there. It's supposed to be beautiful, but advance the slide, please. So that's the hippocampus there, and hippocampus, as Mary highlighted, it's very important for encoding memory, especially for the episodic memory. And advance the slide, please. And you have the temporal pole. That's an integral part. It's almost like communicates between a hippocampus as well as the language network in the verbal memory side. Advance the slide, please. And you have the auditory cortex there that is on the dominant hemisphere, is integrates with your comprehension centers of the brain. Advance the slide, please. And behind that auditory cortex, advance the slide, please. And you have in the dominant hemisphere, you have a Wernicke's area, where is a dictionary of the brain where you comprehend everything. And there is also an area in the basal temporal region that is important on the dominant hemisphere for the language. So as you can see, the surgery can be very different. It could be a selective amygdala hippocampectomy or a temporal pole resection or a larger temporal resection that encroaches into a language areas, or it can go into a basal temporal areas. So advance the slide, please. Many times the studies do not always capture the complexities in the different extent of resection, but there are certain studies which is carefully looked at the impact of preserving part of the hippocampus, preserving temporal pole, or only involving the temporal pole. And it's definitely, if you are able to achieve seizure freedom, of course, smaller the resection, better the functional outcome. But the reverse is true. Bigger the resection, you're more likely to have seizure freedom as well, or more patients are likely to have seizure freedom. Advance the slide, please. So when we look at the data, not all temporal lobectomies are same in terms of the functional. Next slide. Next slide, please. So why does this cognitive change is variable after epilepsy surgery? I have a cartoon to explain this, and there are three scenarios. We have no change, improved, and decline. As you can see in this brain cartoon, the areas that is dark dots are the epileptogenic areas, and the area that is showing in lines is the dysfunctional areas. So as you can see in this scenario, next slide, advance the slide, please. Yeah. We have a child with a right temporal malformation who's 12-year-old, right-handed, so it's not a dominant temporal lobe, and has got a complex partial seizure. Most of the times you do surgery, you take away the seizures. They are either unchanged or maybe slightly improved because the opposite temporal lobe may be able to function better. Advance the slide, please. And look at this scenario. Again, the epileptogenic area is in the temporal region, but the dysfunction is not limited to the temporal region. There is a dysfunction that is extending beyond the temporal region. What is the scenario? Advance the slide, please. So we have again a right temporal malformation here, but we have an 18-month-old child who has got epileptic spasms and a hypsarrhythmia that is producing dysfunction all over. So I would expect as a clinician, if the patient is seizure free, if I take away the epileptogenic zone, the dysfunction on the outside the epileptogenic zone is going to be pretty much reversed, and I would expect an improvement in the developmental outcome. Advance the slide, please. And we have a third scenario here. As you can see, there is not much of dysfunction there. The patient has epileptogenic area there, but there is not much dysfunction. Advance the slide, please. Again, we have dealing with a right temporal epilepsy. In this patient is a left-handed patient, so right temporal is a dominant, and the MRI scan is normal. So there is the epileptogenic zone is overlapping with the functional zone, and in this patient, when we do operate on this patient, we would expect the patient to have a decline in cognitive function. Next slide, please. So in individual cases, as a clinician, I can make some prediction based on the data as the type of epilepsy, what kind of dysfunction, whether the EEG is diffuse, or if the PET scan is showing some dysfunction outside the area, and what is their preoperative scores, and all those things will give some idea for me. But such data is often lost in large studies sometimes. You see only the etiology. If you see, some studies will say malformation, worse outcome. Another study would say different etiology has got a worse outcome. And in our study, when we did hemispherectomy, we did not find the cause of the epilepsy influencing the outcome. But in a given individual patient, it may be different. Next slide, please. So moving on, next slide. The challenges and limitation. The biggest is the age factor. You can load this slide. So as you can see, children have epilepsy right from early life, and the testing the type of test they need is different as they get older, and it is not easy to compare one test versus the other. And even in the same patient, as they get older, they need a different kind of testing, and test-to-test comparison also becomes challenging. Advance the slide, please. And the improvement on follow-up. Sometimes you do up surgery at a 15-month-old child, and then 6 months later they come, they are flowing with their language production. Is this part of the normal development, or is it because of the surgery? It's not always easy to separate that out. Next slide, please. And lumping by the surgery type. Even when I presented hemispherectomy and temporal lobectomy. Again, as you can see, temporal lobectomy is got heterogeneous, and sometimes, especially the larger surgeries like left temporal occipital TPO resections are even much more complicated to analyze the data. Again, epilepsy is different despite being the same surgery. Advance the slide, please. Etiology is different. Advance the slide, please. And the surgery is different except for the hemispherectomy. Next slide. In terms of the other factors, you can load the slide. So it's not easy to sometimes differentiate what is causing the dysfunction. Is it the epilepsy? Is it the cause? Is it the drugs? Is it the surgery? And the need for a pre and post-op testing. And especially in Cleveland Clinic, we are guilty of not doing post-op testing many times. Many times they may be coming outside the state, and they have to visit here for testing, and if they are seizure free, they feel like they are done, they don't want to do anymore. And unless you are in a very active research program, it's not easy to get those data consistently. And the positive changes are often delayed. If you test before 2 years, you may not appreciate especially the positive changes after the surgery, and the small numbers in studies. And in some studies, children less than 70 IQ points are often excluded from the studies because it's not easy to test them. So the key takeaways are 80 to 90% of children who undergo surgery, especially temporal lobectomy and hemispherectomy, they are either unchanged or somewhat better after the surgery. About 10 to 15% do have decline. And this decline or improvement sometimes is predictable. I would say as a clinician, most of the times we can predict some definite declines in some patients. And healthier side works better after successful surgery. Next slide, please. So when we advance the slide, please. So when we entertain any procedure, we are always thinking about risks and benefits. But there is one more additional piece to it, is what is the risk of not doing a procedure? That should always be included in the conversation when we do an informed consent and counseling of the patient. And sometimes that may be the one that is tilting the balance completely. Thank you. Thank you for the opportunity.